And sir, thank you very much for your time. And sorry to trouble you when you're not well. I understand that. So that's okay, sir. Your attendance is important for us, so you can share whenever there's a need. You can definitely share. My sir, as the third session of the series, the third session of the series, sir, we have been conducting this session on basically on surgical site infection and the prevention beyond incision. So first two topics we covered one was talking about the patient preparation, and second was talking about the operation theater preparedness for preventing the infections. Now the third topic we will be talking about having a clean and disinfected instrument so that the infection HIS can be prevented to a larger extent. And in continuation to that, as SANMED, we are always at the forefront of sharing the information with all of them. And for this session, we have Sangeetha madam. Madam, I'll introduce to you, sir, later. And we as on continuation to the session of IPC Masterclass, which has got an extensive, great response for the last five times. So this is the sixth session. Also had a wonderful reception in the last two sessions, which have happened one and two. Also got a very extensive information sharing, and also all the participants expressed a lot of questions in the area of HIS prevention. Not only on giving antibiotics and this thing, they also wanted to have some more information. I hope the same will continue in this session also, and we will be keen to know a lot of new information and important information to all the specialties so that the spread of infection can be prevented and the patient would be at a safer place comparing to the earlier. And sir, it's my pleasure to introduce you. Though you have been on the circle of IPC for quite a long time, it's our duty to introduce you. Welcome, sir. Welcome to the session. Dr. Sanjib Gogoi is an extensively academically qualified, I can say. As you're a techno-commercial guy, sir, not technical guy, because you are into commercial. You have seen the commercials and you have also seen technical of this. So he has done his MBBS, MD microbiology, and he's a postgrad diploma in hospital infection prevention and hospital management clinical research. He also holds a prestigious certification in infection control, including certified infection control CIC from the Central Board of Infection Control USA, and certified infection control professional CICP from CAO India. Currently, he is serving as a professor in the Department of Microbiology at Lady Hardinge Medical College, New Delhi. Dr. Gogoi has previously held roles as an attending consultant at Medanta, Gurgaon, an associate consultant Narayana Health, Delhi, and a medical advisor to 3M in India Limited. His areas of expertise include surveillance strategies in infection prevention and quality assurance in health. Dr. Gogoi plays an active role in several key functions at Lady Hardinge Medical College, such as co-principal investigator of BRDL HMNC, infection control officer, nodal officer for SRL ICTC, and being a member of various committees, including the Medical Education Unit of Antibiotic Stewardship Committee, and he has received specialized training in clinical and molecular genetics from ICMR NIRH, Mumbai. He has also made significant contribution to public health, serving with the government of India in Central Public Health Team during the major disaster responses like Uttarakhand floods in 2014, Kerala floods in 2018, and dengue outbreak surveillance in Bihar in 2022. Dr. Gogoi has numerous research publications in Index Journal, showcasing his continued commitment to advancing the field of microbiology and infection control. Sir, thank you very much for your time. Once again, welcome you to the session. All the sessions are yours, sir. Thank you so much for your time.
Thank you so much. First of all, I would say thank you so much for the introduction, but I consider myself as a student, and though I'm a faculty here and serving, just we are learning actually. So that's the reason when you guys approached me that we are having a session like this in parts education, I was very much interested for the simple reason that I'm going to learn something out of it. So thank you to you and your team for making me a part of this very good initiative to imparting knowledge. And I could see that we have around how many participants? You see, we have around 127 participants, which is like really nice to see that people are interested in the understanding basic principles of infection control and prevention. And sorry for my this petrol. And the topic that we have selected is surgical site infection, which I feel in a country like India, which is much, what do you say, it needs a lot of attention considering our resource limited setups and considering our, the principles that we govern. At the same time, when I saw this particular session where that I'm going to be a part of it, by taking by a professional which is from a nursing background, I was very happy to see. As Sir has told, I was a part of the medical marketing. I was in 3M, and I had a lot of dealing with the nursing professionals. And I strongly believe with this idea that they are the pillars, in quality healthcare. And as you say, quality. So the infection prevention is one of the biggest key factors in maintaining quality of any healthcare setup. So having said that, I'm very happy and excited and to introduce you to all. I have a very experienced faculty over here with 2 decades of experience. Mrs. Sangeetha Chinnaiah. I'm very sorry if I'm making a wrong pronunciation. I'm audible. Mrs. Sangeetha, right now?
Yeah.
And and ma'am has an extensive experience she's of over 2 decades. And right now she is working as assistant GM, general manager, nursing in AIG Hospital, which itself is the flagship name in terms of healthcare in our country. And regarding her expertise, she has got a lot of training and certifications, starting from the Telangana, Asia Pacific Endoleprosurgery, surgery, as well as foundation of the nursing leadership training. Along with that, she has a significant publication in Aaron newsletter. I believe all of you are aware of the Aaron guidelines and newsletter. It's a very prestigious thing to have, where she has published an article on the pottery bones. Her area of interest is on operation theatre, which is encompass all aspects, showcasing her broad knowledge and skills. And recognition to her this exceptional work, she has received several accolades, including a plaque of appreciation award and a certificate of appreciation for maintaining high standard of infection prevention and control in the patient care. So we are lucky to have you today in this session. I believe that all the 125 30 participants are going to be benefited a lot. Since today she's as a session of SSI, and she's going to talk about a very important topic, which we consider, always been, what do you call, somewhere we miss it. It is called a preparation of instruments, starting for infection-free surgery. And ma'am is going to talk about starting from, I believe, from the cleaning, disinfection to the sterilization. So you all are going to have a very good knowledge, updates regarding this particular topic. So I welcome you all and welcome ma'am, and over to you, ma'am. Thank you so much. Thank you.
Thank you, Sanjeev sir.
Thank you.
Yeah. Once again, I will introduce myself. My name is Sangeetha Chinnaiah. I'm working as an assistant general manager in AIG Hospital. And thank you for giving me this opportunity to share my insights on infection-free surgery. And I will be discussing about importance of infection-free surgery and the classification of the medical device and the recall policy and the best practice in the OT and the CSSD. And so these are the main topics I'm going to discuss. The introduction is ensuring the sterile surgical instruments and the medical device is critical to preventing surgical site infections and the maintaining patient safety. The process all involves cleaning and the disinfection and the sterilization and the proper handling. Thus, importance of infection prevention in surgery, role of proper instrument preparation and the decontamination, and the compliance of international standards for the patient safety. The importance of infection-free surgery, the surgical site infection and their impact, and the contamination risk in the surgical procedures, and the role of CSSD and the OT teams in the ensuring sterile instruments, because they are the main people, OT and the CSSD, they have to maintain their protocol and the policy and the monitoring also. And the main process flow in the workflow in the instrument and the preparation. First is the pre-cleaning at the point of use. Second is the transport to CSSD in closed containers, how to transport OT to CSSD, and the manual and the mechanical cleaning, and the inspection and the function testing, how it will be working, or the instruments and the medical device, and the packaging and the sterilization, and the storage and the distribution to the OT after the sterilization. The first is the pre-cleaning of instruments, how we are doing the once the surgery is over, and the in between surgery also how we are cleaning the instruments, we can see in this video also. And the first is immediate cleaning to prevent the biofilm formation, and the pre-clean instruments immediately after use by wiping of the visible debris, that we can see in this video how we are after using once they receive the table, how to wipe the instruments also, and use of enzymatic cleaners and the detergents, and the pre-treatment with the foam spray if transport is delayed, and the rinse thoroughly to remove all detergent and the residues. The foam sprays when we are doing after the instruments before transporting the CSSD, this spray we are using because of any blood clot, any tissues are there, it won't stuck into the instruments. When we are spraying this foam spray, it will give the moisture to the instruments. They're very easy to clean the CSSD. Now we can see this video how we are doing the cleaning. So we are using the sterile water and we are wiping the instruments to remove the blood clots and the tissues. Yeah. So like this, once the instruments receive in the table, we are wiping the instruments, and after that we are spraying this foam spray we are using and then send it to the CSSD. Now the transport of soiled instruments. So after the foam, the spray, then we are collecting all the instruments and we are using for the closed containers and the trolley. We can see here in the pictures, closed and the leak-proof containers and the color-coded bins for segregations and the dedicated pathways OT to CSSD to prevent the cross-contamination, because we have two sterile dump waiters. One is for the soiled dump waiter and second is the sterile one. All used instruments we are using and we are sending through this post box. Other side is the CSSD person is receiving the instruments, and this side is the OT staff is handovering the instruments. After that, all the instruments we are keeping this closed trolley, and this trolley will keep into the soiled dump waiter, and the dump waiter connected to directly in the CSSD, and we are taking through that we are taking to CSSD. And the decontamination process, it's a 3 types. One is the manual cleaning, and the second is ultrasonic cleaning, and third is automated washer disinfectors. First is manual cleaning. Yeah, we can see here all the instruments we are putting in the enzymatic solution, and we are using the soft brushes and scrubbing the instruments. And the ultrasonic cleaning for the complex instruments, this ultrasonic instruments high frequency sound waves, this will helpful the remove the debris and the blood clot and the tissues and the fluids. And this ultrasonic cleaning for the maximum lumens, like a catheters type of instruments we will use it, and the automated washer disinfectors for the high level cleaning. So for this cleaning, for it will saving the manpower and the standardized cleaning and the improved safety and the prepares for the sterilization. So the automatic washer disinfector, all the surgical instruments except dedicated and the catheters we are not doing, and the electronic devices also we are not using in the automated washer disinfector. Only instruments we are keeping in the machine inside. And the understanding the Spalding classification system for the medical devices, it's a critical device, semi-critical device, in the non-critical device. These are the 3 categories are there. And the critical items enter normally sterile tissues, the vascular system, or equipment through which blood flows. Items must be probably and the safely pre-cleaned and the sterilized before use. These instruments included laparoscopic instruments and the instruments and the catheter. This all inside organ and the abdominal inside we are using. That's why sterilization is mandatory, and these are under comes the critical items. And the semi-critical items contact only the mucous membrane but do not penetrate soft tissue or the body surfaces. This meticulous physical cleaning followed by the appropriate high-level disinfection. We can use it for the Sidex, and second is H2O2, hydrogen peroxide sterilization. We can use it for this. This semi-critical item examples: flexible fiber optic scopes, respiratory therapy equipment, anesthesia equipment, and endotracheal tubes, bronchoscopes, and the cystoscope. And the non-critical items, direct contact with the patient intact in the skin. It is not in the inside and it's not in the mucous membrane. It is outside the skin. So little risk of pathogen transmission directly to the patient. And clean and disinfect, use a low intermediate level disinfectant like alcohol swabs, and that alcohol swabs like alcohol related solution, we can use it for this items for the cleaning. These are the example item like a blood pressure cuff and the stethoscope, face mask, and the X-ray machines. Inspection and the testing of instruments. How we are doing once the cleaning is happened, how we are rechecking the instruments, functionality testing, any broken, any crack, any tissue, any clot attached to the instruments. So here we are doing the inspection. It is the visual inspection for the residual debris. The table is in the CSSD, the magnification tools and the detective micro damage, the light also attached with the CSSD only. Each instruments, once it is clean is over, then each instruments they are checking. If anything damaged and the broken, if any they found, we are not using and we are not keeping in the set also. And the packing of instruments. Clean instruments are packed in sterilization pouches and double wraps or containers to maintain sterility. Use of sterile barrier system, proper labeling with the sterilization indicators. We can see these pictures. This is the AIG Hospital CSSD. So we are doing the inspection here, and the same next table only we are packing the instruments. The packing also double wrap we are using. If one is damaged also, another is there in the sterile. So that's why we are using double wrap. And the proper labeling also we are doing. In this label, which is set and the how many instruments, everything it is, we can see here the labels, and the date and expiry date also it will be there. And the sterilization methods, we have 4 types: steam sterilization, ethylene oxide ETO, and the hydrogen peroxide plasma for the delicate instruments. Dry heat sterilization we are for the special items, but we are not using in the nowadays, we are not using the dry heat sterilization. So storage and the transport of sterile instruments. Sterile storage in the CU clean utility we used to call. In their temperature and the humidity control, it is very important. And less than 24 degrees Celsius, we need to maintain the temperature. Humidity 40% to 60% is the normal value. We have to maintain that. And the always sterile instruments are stored in clean, dry, and the control environment. And FIVO, first in, first out for the timely usage. Whatever the items we are keeping in the sterile storage, first we need to check the expiry date. According to before the date only we need to use it. Otherwise, if we didn't use, we need to send it to again the re-sterilization for the CSSD. And the expiry dates and the sterility indicators are checked before distribution to the concerned departments. Yes, the biological indicator results, after the results only we are distributing the sets in the concerned departments. If it is in the failed, then we are calling the recall policy. Again, we are not sending and we are not issuing. Again, re-sterilization after the reports only we are sending to the departments. Label and the sterilized instruments with the date and batch number we are for a tracking purpose. We are maintaining the CSSD register in the OT also. What are the internal indicators, chemical indicators? Once we removed, it is sticky one. So we are maintaining the register, CSSD register. So patient detail, the same way which set we are opening, the set detail, and the same indicator also nearby there only we are placing for the tracking purpose. If it is any problem, then very easy to tracking. That's why we are maintaining the register in OT also. used closed trolley for the safe transport to the OT, maintaining sterility. Always any sterile item or the soiled item we are using for the separate closed trolley with the label and the separate dumbwaiter only. It is the one way. It won't come in the same route we are not using. One dumbwaiter if we are taking to CSSD, after sterilization, after sterilization, we are taking another dumbwaiter to the CU. And the recall policy, no color change of chemical indicator. If any chemicals, the indicator is color is not changed, immediately we are calling the recall and we are informing the CSSD manager. And once the open in the set in the OT inside before surgery, we are checking the pack is wet or not, and the notice the blood tissues in the pack or in the instruments or biological indicator results positive growth. So these are the reasons we are not sending the set to concerned department. And the OT after opening, if we found in these 3 points, then we are calling the recall policy. We are calling it CSSD manager. Immediately the set sending back to CSSD and they are doing all recall items for the re-sterilization. And the best practices for the OT staff: perform biological and the chemical indicators to the confirmed sterilization effectiveness. So always the biological indicators, they used to check it in the CSSD, the report received from the microbiology, the chemical indicators checked by the OT staff in the before starting the surgery, after opening the set. And avoiding contamination during handling, even handling time also, in between surgery and during the surgery also, they cannot, instruments here and there, they cannot keep it. The sterile area only they have to keep it to avoiding the contamination. And regular inspect instruments for the damage or crack before use. Any instruments, any damage or crack, any blood clot, any tissue found in the instruments, we cannot use that the instruments for the surgery. Immediately we are sending back to CSSD. And maintain strict aseptic techniques during the surgical setup and the handling and transferring the sterilized instruments to the surgeons also. Not only surgeons, in the assistant surgeons, whoever there in the surgery, wherever we are giving the instruments, we need to maintain the very strict aseptic technique. And the follow the manufacturer's guideline for cleaning and the sterilization methods. And these are the international guidelines we are following in the CSSD OT in AIG Hospital, as the WHO and CDC, AORN, ISO, AAMI. AORN is nothing but Association of the Perioperative Registered Nurse. ISO is the International Organization for the Standardization. This is for the sterilization process. We are using this guideline. And the AAMI, Association of the Advancement of the Medical Instrument, steam sterilization purpose, we are using for the this guideline we are using. And the regular audits of the OT environment and the training to maintain the compliance. And the conclusion is proper instrument preparation, minimize the infection risk, and the collaboration between the OT and the CSSD teams ensure the safety. Continuous training and the process improvement is key, because every 3 months, every 6 months, keep on the staffs are changing in the CSSD and the OT. So because of that reason, continuous training is process improvement. Thank you.
Manisha, I think we can run one by one poll.
Yes, sir. I'm launching.
Yeah. Audience, there is a poll available for this session. So we request all of you to participate and respond to the poll. And accordingly, Madam and Sir can reply to the questions which are coming up. Request you all to put the questions on your chat box or in a question answer session so that experts will answer all your questions. Madam, you can also see the poll from your end. The first question is, what is the recommended method of pre-cleaning a surgical instruments?
Yeah. Sorry. Repeat the question, please.
It's available on your poll, madam, on the right side of your screen. The first question is, what is the recommended method of pre-cleaning surgical instruments?
Pre-cleaning in the, as per the, in AIG Hospital in OT, we are not doing the pre-cleaning. It is happening in the CSSD. Entire cleaning process is happening in the CSSD. But before sending the instruments, we are doing that foam spray. So the clot, the tissue won't attach to the instruments. And during surgery, we are wiping the instruments. That is, we are called for the pre-cleaning.
No, and the options for madam, rising with plain water, using an enzymatic cleaner.
No, no.
Or-
NS we are not using. The sterile water, we have to use it.
I think.
I'd like to add here, as madam has rightly
Yeah, exactly, sir. I think you can take over.
where we are not using NS because those things when there may be the deposition of the salt and all in the instruments, so
Yeah.
that is not like to use normal saline. Rather
Yeah,
was
normal
ma'am
saline
has-
or the distilled water.
or distilled water. Not those
Yeah.
things. Be little careful with that. And always, as ma'am has mentioned, like there are recommendations available or general recommendations for instruments. So what I believe we should go ahead when you have some business instruments or starting some instrument like laparoscopic and other probes, you should always kind of go with the manufacturer's protocols, which is I think a safer thing to do. The ma'am will also agree with me. And definitely the CSSD has their own protocol for cleaning. And the importance of pre-cleaning that the OT people or the surgeons or the nurses, they should understand the importance of pre-cleaning. That is more important, I think, to guide them. That's what I wanted to. Thank you. Second question, sir, are you because I'm taking it, how should soil surgical instrument be transported to CSSD? Hello. Hello. How are you doing the transportation of instruments like soil instruments to the CSSD? They want to know.
After spraying that instrument, we are keeping in the closed container. Then we are in that container, we are keeping in the closed trolley. I showed that picture. In that
Yeah.
whole trolley, we are taking to the one separate lift. We will take it all the soiled instruments and the items taking to the CSSD, the separate lift. It's called the dump waiter. So we are taking that closed trolley to that. After that, we are once receiving the CSSD, we are opening that set and the we are opening the closed trolley. Then we are removing that closed container. Then we are taking the instruments and we are starting the cleaning process.
Okay, that a very nice point, ma'am has focused that they're using a separate lift for all the
Yeah.
soil thing, which is as per guideline, which is recommended, which is to be
Recommended, yeah.
recommended. But at times you may be working in a hospital, as for example in a Robert setup also. So you may not be possible to have a separate lift at times.
Yeah,
So
correct.
what
But
I-
we can use the closed container. We can use.
Closed container. That's the thing. I think all the participants should remember, closed container. But at the same time, if you're taking anything soil in a lift where also otherwise used for other items or patient care. So the important thing is to clean that particular lift or taking that instrument in a closed container. After
Yeah,
every
closed
time-
container is ideally for the cost reduction also it will happen because most of the
Exactly.
hospitals, they don't have the separate lift. So in that time, we can use it for the closed container is more than enough for that.
More than enough. That is a very good point. But the third question is, why is visual inspection of surgical instrument necessary before sterilization? Why you need to check it visually before going for
Visually,
sterilization?
yeah. Some of the instruments crack, we cannot see in the normal lights. So each instruments, why it is required, some tip we will miss in the abdominal cavity or organ. It's very difficult to found in that. So again, we are leaving the foreign body in the human body. So that's why any crack is there, continuously if that crack instruments, if we are doing sterilization, multiple sterilization, if we are using it, the chances of broken in the abdominal cavity or any other surgery part also. So because of that reason, we need to inspect. Visual inspection is very, very important for the instruments.
Exactly. And to add on to it, as a ma'am has beautifully explained, sometimes the instrument, there is a wear and tear of instrument also if you're using over and over again, even from a sterilization procedure. So
Yeah,
that's
it
why
is
again,
still.
yeah. So if there is a continuity, is break in the continuity, the smoothness is gone. There is some blockage in the lumen of the scope. So there is a possibility of going to give a SSI or hospital infection. That is why
Yeah.
it's always advisable to go ahead. Yes.
And
And
when we are, yeah, sorry for the interruption, sir. When we are
no, no,
using the rusted instruments in the surgery, the
yeah.
common, the SSI also increasing, sir. So because of that reason, any crack, any rusted instruments, even though some example needle holders in the tip of that, the rusted, it is in the small areas. We couldn't find in the normal lights in the normal inspection. So because of that
Yeah.
reason, only magnification inspection is important, sir. So yeah.
The fourth question is, I think ma'am has already explained this one. Which of these organizations provide guidelines for infection prevention research? Ma'am, I think you can show the slide already. Like, what are the guidelines? What are the organization providing guidelines? He's already mentioned. Ma'am, you can.
Madam, you can answer.
Sorry.
You can answer, madam. They are asking the question is which of these organizations provide guidelines for infection prevention in surgery?
You have already mentioned, ma'am. That is what.
Yeah. WHO, we are using for, these are the international guidelines. WHO and the CDC guideline, Center of Disease Control, and the AORN guidelines, and the ISO guidelines, and the AAMI guidelines we are using, sir.
Yeah. And on top of it, I'm pretty sure that for the air, because air and ventilation is also a very, very important part of an infection.
Yeah, that OT environment, audit also, it's very, very important, sir.
We also have our NABH guidelines for OT air condition. I think definitely we use that also. Yeah. And the last here is, how would you rate your overall experience of the webinar on preparation aid? That I think that will be done by the participants. This question. Hello. So we need to rate, or the participants are going to rate. Hello.
Hello.
Sir, in the question and answer section, we have few questions.
We have questions. I can see. I have polls.
Question.
The polls.
No, sir. Question and answer section. Besides
There
chat,
is a section on the QA, sir. On that, there are some questions.
Yeah, in the chat box also there are a lot of queries. I think that some people didn't able to listen to the voice, and Q&A section, then possible to share document. They are asking if possible, can we share some document with you? Would you like to take up that, Ganesh? Yeah. Hello.
I can answer this.
ma'am, your voice is not on.
Sorry.
Your voice is not clear.
Hello.
Your voice is not audible, I guess. Yes, ma'am. They're asking if is it possible to share with us any document. I'm not really sure. I think can you be a little specific? Whosoever asking the question, Nikio Bio Ora, if I'm pronouncing it right, that what kind of documents you're looking for? Are you talking about the PPT, or are you talking about some guidelines related to infection-free surgery or sterilization?
Hello. Can I audible?
Yes.
You're audible.
Yeah. Who's the in charge for CSSD, microbiologist or anesthetic? Obviously, it is the microbiologist only. Under the microbiologist, the CSSD technicians will work.
Ma'am, yes. Another good question I could see, because I'm driving, is a recall policy. They want to understand more about the recall policy. I can understand it's a very, very important part. You have also mentioned.
Yeah, I can explain, sir. And another question is
Kindly.
it is recommended for the seropositive patients surgery. So fogging.
Yes.
Hello. Actually, the CDC guideline fogging is not recommended for the regular purpose. The surface cleaning is more than enough for the fogging. But the seropositive, it's a once in a while. End of the day, we need to take a case, and the weekend only. So, yeah, once in a day, fogging is acceptable.
Yeah, I would like to add on to this, and ma'am has said, and nowhere in the CDC guideline, if you see 2003, 8, any other guideline, the
Yes, sir. Surface
fogging
cleaning only
is
they
not
are
recommended.
suggesting.
Only surface cleaning and deep cleaning, and the cleaning of the frequent cleaning of the high touch areas. And as
Yes.
we know, as all of you are aware, is the cleaning in between surgeries, cleaning the first cleaning of the day before the surgery, the cleaning before the in between the cases. Then there is something ma'am has told, the terminal cleaning of OT, and you'll see a lot of guidelines even in Kayakalp guideline. You can see how to do a terminal cleaning, that we can make your own schedule for that, how you're going to do clean at the end of the day, and as well as a deep cleaning after a week, like week cleaning, and what agents you're going to use, how you're going to take out all the lights, when the fan, the walls, floors, how you're going to clean. You should make a protocol, and for daily cleaning different times, end of the day terminal, and after the week, the week, and any day you can fix that protocol. Needs to be maintained. Yeah.
In the OT, the beginning of the day we need to clean. In between surgery, yes, we need to clean the 20 minutes. In the during surgery, any spillages is there, that time also we need to clean. And the end of the day we need to clean, and weekly once we need to clean, and weekly once in the complete theater need to clean it.
Where you
Yeah, these
clean
are
the
the
lights,
clean.
yeah. So for that, the participants, you can refer to the guidelines and see the exam. The easy one is a Kayakalp guideline also. Make your own skill. Yeah, ma'am, you're supposed to talk about the recall policy. Can you kindly take it?
Yeah. Recall policy. First, we need to see the biological indicator. The results is positive, then the batch instruments full, we cannot, distribute it to the concerned departments. So we need to do again the re-sterilization. Again, in that batch also, we need to keep the biological indicator. Then again, we need to go to microbiology department. Once the report is negative, after that only the sets issue to the concerned department. This is the first point in the CSST based. Second is, after the biological indicator, the negative report, once we issue the sets to the OT, when they are opening the set, they found the pack inside wet, or the indicator color change is not happening. For example, ETO, the orange to green. So like that, the color code is there. So the color is not changed. The second point, and any blood or any tissue we found in the set, we cannot use the set for that surgery. Immediately, we need to call the recall policy. The set back to the CSSD, and they will found the which batch set, and the entire batch set, they have to call the recall, which are the department they issued, and they have to do root cause analysis, where it has happened and what happened exactly. After that, if it is any blood stain or in the any tissue in that set, they have to do the cleaning process thoroughly, and then again re-sterilization. After that only they have to issue the concerned department, either OT or any other department like cath lab or dialysis or any other departments. So these are the main points.
Yes, babe. And I think if the microbiologist, definitely experienced microbiologist are there. So you can always make your recall policy discussing with your surgical department, which is also essential. And it might vary a little bit depending on the ma'am as to what sterilization process your instrument has gone through. All the chemical indicators, whatever you are putting, should give the positive result. That is why while receiving the instrument in OT, the inspection, whosoever is receiving the inspection is very essential. I believe that everyone is maintaining that.
Yeah.
But obviously, it depends on your hospital level, how you are going to maintain it. Yeah, that's it. Any other question there? Yeah. Okay. Please drop the question here. Okay, what is the criteria for surveillance of OT and ICU? What is the colony count criteria?
Ma'am, how are you doing this in your OTs? Are you doing it in a air sampler or a settle plate, which is an older method?
Oh, sorry, sir. We are doing surveillance in the OT, even though CSSD also, CSSD in the sterile storage area we are doing, and the OT air sampling we are doing, and the swab also, swab culture also we are taking for the every month. And if it is any positive, then we are not allocating the any surgery and we are doing the shutdown. Once the report is negative, then we are opening the OT. And if it is in the, we found in the CSSD area, the sterile storage area, if we found in the positive, then we are not keeping the sets there. Alternatively, we are keeping in the OT sterile area and we are doing recleaning. And after the, once the report is coming in the negative, till that time we are keeping the sets there. And after that, the regular process we are starting.
Yeah, about the colony count and surveillance, I believe actually this particular talk is about clinical instrument and all. The surveillance is a very, very deep microbiological question. There are a lot of, I'll not go into it, but I'll just mention one thing for this question. Sultan has asked that for the different OT, your criteria are different, as you know. If it is a general OT and if it is a neurosurgery OT and the ortho OT, the colony count criteria and even the what organism you have found in the air sampler will vary. So that you need to follow the guideline. I'm not going into the deeper part of it. It's a very microbiological question, but as for nothing short, I'll say colony count criteria will be different depending on the what type of OT you are doing. Next, who is the child? I think you have taken this question. Yeah, fogging you have taken. Any indicator compulsory for ultrasonic machines after hearing instrument? Our indicators are compulsory. Okay. Do you require any indicators? Whether the cleaning has occurred properly after ultrasonic machine cleaning. That's what they want to know. Would you like to take up? Am I audible?
Hello. Hello, can I audible?
Yeah, you're audible, man. They want to know, are you using any kind of indicator in your ultrasonic cleaners?
Yeah, it is there, sir. We are maintaining that.
Okay.
Yeah, once in a while. So when we are using the ultrasonic instruments for the washing, so we have that sticker. It will used to, come along with the machine. So once the cycle is over, the report will come. So that report we are maintaining in the register. Yeah.
Okay. The report itself shows whether they have maintained all the parameters or not. Yeah.
Parameters. Yes, sir.
Got. And I think have you taken this question on neurological instrument? How are you doing handling the neurosurgical instrument? Any specific handling technique or something of neurosurgery?
Sorry, sir, not audible.
They want to know how are there any specific mention or are you handling the neurosurgical instruments in a a very special way? Like, is there any other protocol?
Specific mention from surgeons to CSSD. Yes, most of the neuro instruments, it's a very delicate instruments. So we are using for all it is the manual cleaning because it is very delicate. So that's why the surgeons also instructed. So they used to take care of this instrument. It is very costly and the delicate instruments. So according to that, the CSSD technician also for the cleaning and the inspection, everything we are doing.
Okay. Another thing is an important question: how to wash the serology positive patient instrument? Like they mean to say, if it's a retro positive like HIV, hepatitis B or C, if you have done, then how will you go about it, the cleaning of those instruments?
Yeah, the serology positive patient, most of the items we are doing for the disposable. So once we use it, will be discarded. The reuse instruments like steel instruments, so metal instruments, we are taking to the separate closed trolley. We have a container, the separate serology positive container. So we are taking that container for this instruments to the CSSD. And first, the instruments we are soaking for 15 to 20 minutes in the enzymatic solution. After that, we are starting the regular cleaning process.
Okay.
So these instruments will not mix into the normal instruments. We used to do in the separate only. After that, the whatever the solutions we are using, everything we are discarding.
Okay. Okay. Yeah, but that's a very kind of a tricky situation at times. If you have your resources, then you can go ahead. Otherwise, we're doing it in a separate, sterilization is the key for that. And also in the lean and management of those patients, also how we do, what temperature we take and how we wash it separately. That is also one part we need to know that. Yeah. And as I say, all the surveillance question I'll not take up because it'll take a long time. It's a core microbiology questions. Kindly go through the guideline and whether surface sampling is recommended for OT and CSSD routinely. The word routinely, ma'am, please take it up or I'll add later. Yeah. They're asking whether are you doing OT and CSSD surface sampling or microbiological surveillance. Am I audible? Hello?
Yeah. Please repeat the question, sir. Sorry.
Yeah. They want to know whether surface sampling, are you doing surface sampling of OTs and CSSD routinely?
Yeah.
Or is it recommended? Hello?
Your voice is not clear, sir.
The last question, ma'am. There's a last question. Kindly see. Surface sampling whether recommended for OT and CSSD.
Yeah. It's monthly once it is recommended in the mandatory also surface sampling because in OT all the surfaces monthly once they used to take and they have air sampling and swab also they are taking. Even though CSSD also not for all areas, only the sterile storage we are taking, sir.
Yes. Because CSSD also got different parts in different areas starting from.
Correct. We have trolleys and these are the areas we are taking in the surface sampling.
Yeah, to add on to it, I think the more, as we already mentioned, the CDC guidelines says, that fogging and the surface sampling routinely is not actually recommended, but we need to do it at times. But as you asked that, whosoever is asking a question, Dr. Khyati Jain, is, routinely the word, if your ventilations are proper, air handling units are doing fine, your HVAC system is doing fine, you are doing proper sterilization of your instrument, if you're doing a proper the cleaning, surface cleaning of OT and everything, then that the routine sampling of surface sampling takes a backseat. That is my take on that. But again, it depends on the setup. If you have everything at place, then it's not essential. But otherwise, different depending on the OT setup, depending on the resources, people they tweak their guidelines a bit. As ma'am has said, in their setup, they do once a month, which I think it will be an add-on to whatever other practices they do. Yeah. Is fogging recommended seropositive? Question answer you have already given, only deep cleaning. Fogging seropositive, what you want to do with the fogging of the seropositive? Because I would like to take one thing for fogging, because all the time people are talking about fogging. What do you want to do with fogging actually? Fogging is nothing but, if you take it in a very, simple scientific way, that you are giving some moisture, like, water particles in a way, and they get attached to all the droplets, small droplets, which are, that they are floating on air. And what they are doing by getting attached to that water molecule, by their fogging, they are getting settled down. So, end of the day, you have to do a deep cleaning. So, in case of seropositive patient, a deep cleaning is more essential because they are not a patient who has TB or something where you're going to have a droplet infection or airborne infection. So, here, that more important is a deep cleaning. And also the management of linen is an essential part also. And you are having this seropositive patients. And the instrument ma'am has already. Anything else?
Sir, in chat section we have 3 more questions actually.
Okay. Again, I think we are sampling. How can I send, ma'am? Can you please explain? Ma'am has already told, the air we have certificate, which is not very recommended, but if you don't have an air sampler, then you have to go for certificate. please read it, any of the guidelines and the normal microbiology books. And if you have a air sampler, nothing like that, because a major quantity of air the machine sucks into. So, and the plating is very uniform. So when doing the colony count becomes easier. Recommended is air sampling. Are you doing ICU air sampling or surface swabbing? Again, routine recommendations, I would say, are still, depends on what kind of setup you have, how you have air handling unit and HVAC system, whether your deep cleaning protocols are in place or not. Depending on that, yes, we can go ahead with the air sampling and surface sampling, but I would not say that this is enough. But you need to take care of your, the cleaning protocols more seriously. Definitely we do ICU sometimes, but fogging is not recommended. I will go with the guidelines. HEPA filter testing, yeah, very good. If you are sending your HEPA filter for testing for the HEPA, even the NABH has got guidelines and when to send, how to do a maintenance checkup for your air handling units. If you're doing it, very good. On top of it, if you want to do, keep a check once in a while, air sampling or the surface sampling, it's good. There's nothing wrong doing it.
For this,
Doing HEPA, then, ma'am, please add into it.
sorry, sir. This HEPA filters, yes, yearly once we need to change the HEPA filters, and 6 months once we need to do the duct cleaning. For the reporting, maintenance reporting. But yearly once we need to change the filters only,
Yeah. And
including
they come
robotic cleaning, the duct cleaning.
Yeah, and if you want to read further, there are different types of tests available. How they do the testing, HEPA is working fine or not. There are a lot of modern things coming up, and you can check it. Yeah, the gas gangrene thing is there in the guidelines. Also, they have written. But there are few things along with the gas gangrene. Yes, the Clostridia infection they have particularly mentioned on that. That's a very rare situation. You can add into it the deep cleaning and other stuff, and fogging. That's a very rare situation. This is mentioned in CBC, but for general purpose, we discourage and we encourage more of surface cleaning than others.
So I think we have come to the conclusion of the session. Thank you very much for your time. Though you are not well, you have addressed most of the queries. Thank you so much, madam, for your time. And thank you so much, sir, for facilitating the whole session and moderating it the best possible. I think most of the queries are, if anything else is there, to write back to us. Experts can send the reply to you. You can send them the questions to us. So our colleague will forward to them and you will get the expert answer to that and we will refer to you with the answer from their side. Thank you so much for your time. Thank you so much for all of you for attending. It's been a nice interaction, an extensive session. So thank you so much, sir. Dr. Gogoi and Madam Sangeetha. Thank you very much for your time. Thank you all for attending. We look forward to meet you again in the next session, which is on next Tuesday between 3 to 4 p.m. Thank you so much for your time. Thank you, Manisha.
Thank you. Thank you, sir.
Thank you, ma'am. Thank you, sir. Thank you, everyone.